Mas repente, solta tu window. La ilaha illallah. Mana cigarette? Cigarette mesti sudah guli ya. Hah? Mana? Udah kan?
Good afternoon, guys. How are you? How is going on?
Good afternoon, ma'am.
You hear me clearly?
Yes, ma'am.
Okay, that's good. Okay, so.
And what about you, ma'am? How are you? How's your health?
Thank you. I'm fine. Thank you. So, never, yes, this good status, like never give up. So, never give up. Let's start our practice or lecture. I'm sorry. Okay, guys, before starting our lecture, I have some questions. I hope you didn't forget previous lectures about ECG. So, can you tell me please how the outer surface of the cell membrane is charged normally if it's not in an excited cell? So mean rest cell. Who can reply? GM7. Fahad. Okay. GM14 leaders. You hear me, guys, or I muted my voice again?
Yes, ma'am, we can hear you.
Okay. So can you please answer my questions, or you don't know? Sheraf Kanhan, do you know something?
Then the membrane is positively charged outside.
Are you sure?
Yes, ma'am, he's saying correct. When the cell is not excited, is charged positively outside and negatively inside.
Okay, yes, you are right. If the cell, instead of depolarizations and repolarizations, so
Ma'am,
how will be charge the cell membrane?
ma'am, during depolarization, its cell membrane is negative outside and positive inside. But when repolarization happens, it's again become negative inside and positive outside.
Who is reply to me? Your name?
Muhammad Kashif, ma'am.
Okay, thank you. You are right. Study, really? I'm very glad. Okay. Can you, Kashif? Okay, I understand you know something, so don't reply me. I want to see somebody knows more or not. What does mean pacemakers? What does it mean pacemakers? Who knows?
Ma'am, such cells which
Small
can
device it is used to treat
depolarize
And
arrhythmias.
pacemakers are the
and repolarize
group of cells
continuously.
that they
Someone who
perform
wants
heartbeat.
not to
They
at
have
the
the
same time.
automates.
Smatula, can
Yes,
you
ma'am.
repeat? What does mean
Ma'am,
pace?
pacemaker is a small device which is used to treat some arrhythmias uh, in some diseases in which SA node is not sending the impulses. So an artificial pacemaker is required during arrhythmia in which heart can beat too fast or too slow with an irregular rhythm. So pacemaker send the electrical pulses to help your heart at a normal rate.
Can you tell me, please, what is the main pacemakers and how much impulses generate these pacemakers?
Ma'am, SA node is a pacemaker of the heart. It generates the impulses.
How much
Can you
impulses?
hear me?
How
Uh,
much?
ma'am, we uh,
3 pacemakers.
No,
50
no,
to
no.
100 times per minute, ma'am.
70, 80. 70, 80.
72 BPM is normal, and ma'am,
No,
SA.
no, no. SA node generates 70, 80 impulses per minute.
Yes,
Okay.
ma'am.
Okay, thank you, Asmatullah GM13. Okay, let's see next questions. Sequence and time of coverage of excitations of the right and left atrium. It means how excitations or how um, impulses, how depolarization and repolarizations going in the atrium. There is like rules by one by. So how can you reply to me? Somebody who knows. Mm,
Ma'am,
yes.
excitation originate in SA node first, then it's propagated through both atria, and then atria depolarization to the AV node, and then it's passed through the bundle of
No,
position.
I'm not asking whole. I'm asking about atrium, about left and right atrium. Where it starts, okay, I understand. SA node
From S
starts. Yes,
and
but you should know how it excitations happening.
how it's happening.
No means how it is follow or going sequentially or step by step. Only atrium, don't touch
Okay,
ventricles.
first SA node generate impulse, then AV node
No, no. Till the AV node, till it get the AV node, what's happening with excitations?
Okay,
Where it
okay.
goes?
When SA node send electric impulse, so then it's travel from SA node through muscle cells in the right and left atria.
Uh, not right, but very, very close, but not right.
Ma'am, when SA node generate impulse as cells of atrium are connected to each other by gap junction. That's why when cell depolarize, then it's uh,
No, I'm
calcium is also
not.
depolarized.
No, no,
Can I try, ma'am?
no. No, sorry, but no.
When the SA node generates the impulse, it goes into the both part of the atria by the Beckman's bundle, and
Ma'am,
Okay,
that is
close, almost close. But
with the Beckman's
exact-
bundle, and it generates impulse in the
ma'am,
atrial muscles.
node,
And
the excitation wave distribute throughout the atria from the bottom from SA node to the AV node.
no.
Right,
No.
JTM is right.
I need exactly. Don't touch AV node till the excitation comes from SA node.
From
And
endocardium to epicardium in the
what
map.
happened till the AV node? What happened? I say to you a lot of times, this is the rules of ECG. You must know very properly and clearly. You cannot say or think near, almost.
Ma'am,
No.
first the interventricular septum is excited.
Excuse me, can you repeat, please?
Ma'am, interventricular septum.
No.
Ma'am,
SA
endocardium.
Ma'am, current goes from first they depolarize right atrium, and then it travel leftward and downward, and after right atrium, left atrium depolarized, and it travel rightward and downward through gap junctions.
Okay, almost right. But what through what? Through which tract?
Ma'am,
Or
PV.
no. Through
Internodal,
what?
ma'am.
How it's happening?
Beckman's
Tract,
internodal.
Beckman tract, which, who else?
Ma'am, atria, internodal tract.
Internodal.
Muscles.
No. Which tract? I need a name of the tract that
Internodal.
excitation is going.
Internodal tract.
No, you all don't know. I will not say the answer. Okay, next questions. What is the maximum number of pulses per minute an AV node can carry out?
Ma'am,
40 to 60.
Excuse me.
60.
Can you repeat, please?
Ma'am, 40 to 60 beats per minute maximum.
Okay, but
normal,
it is the normal.
90.
Excuse me, can you repeat again? Repeat me,
Name
please.
60 to 90.
Okay, so questions, it sounds like that. Not generate. How much impulses can AV node allow go to the ventricles? How much AV node can allow go impulses to the ventricles? How much?
60 impulse per minute.
It is normally, but I am asking till in how much? In how much they say AV nodes say no, never. I never let you go to the ventricle. Which numbers?
100.
Huh?
Above 200.
180. 180. Yes, you're almost right. Like 200 or 180. Okay. Next questions. How does the wave of depolarization propagate in the thickness of the ventricular myocardium from epicardium to the endocardium or from the endocardium or to the epicardium? Tell me, please.
Endocardium to the epicardium.
Endocardium to the epicardium. Okay. Can you tell me, please, what does it mean, ECG?
ECG, ma'am, it is
Electrocardiogram.
graph procedure that
Selection of electrocardiogram.
electrical cardiac activity is shown in a graphical manner.
Graphical representation of the
ECG,
activity of heart
it
rate.
means electrocardiogram
Cardiogram.
or electrocardiograph.
Yes.
Voltage
But
versus.
yes,
Ma'am, it is a test that checks
One
how heart
machine
beats.
which is used to record the
Heart by
activity of
wiring.
the heart.
With the M.
okay, so ECG
Electrocardiogram.
is the electrocardiogram
Gram.
for what? For why?
For
What
It
is
is
it?
measuring the
It
electrical
records the
conductivity of the
electrical
Graph of
signal.
signals or
voltage
electrical
versus
activity
time
from
of
the heart.
electrical activity.
It's so funny when at the same time talking like 10 or 15 students. Okay, you know this. I'm glad. Let's next. Okay, again, this picture. I want to ask how many groups we have. I would like to ask liters of GM9. Liters of GM9. Okay, absent. Yes, why we need it? I would like to ask Fatma Sapleen. She's also absent. She is also absent. Check please, guys. Hinagul, GM7. Hinagul, GM7.
The first one is the P wave, and it represents the atrial depolarization. Then the straight line is the isoelectric line, and it represents the avinodal silence. Then a small curve which is directed downward. It is the Q wave. Then R. Then S. It is the QRS complex, and it represents the ventricular depolarization. And then a plateau phase, and then which represents the ventricular depolarization.
What happened?
Yeah.
Okay, Hinagul, keep going. Hina.
हाँ good thanks.
यार खुदा का खौफ करो, क्यों डरा रहे हो लोग?
Yes, ma'am.
Okay, Hina, keep going. Unmute yourself.
Yes, ma'am.
Okay, so QRS, it's a depolarization of the ventricles.
Then the straight line represents the plateau phase, and it is also called the ST segment. And then the curve is, then the next curve represents the T wave, and it is the ventricular repolarization.
Okay, can you tell me please, Hina, why P, R, T, there goes to the upward?
Ma'am, in galvanometer, they show the positive deflection.
Why?
There,
Why positive reflection? And why Q as they're going to the downward?
Ma'am, their vector is directed
Vector is that
towards the negative pole. That's
okay, towards the negative leads to
yes.
towards the negative. Momentum vectors is the directions to the negative leads. Okay, so actually today guys we are going to talk about each waves, each segment complex, and why it goes and how they are reflect in our leads. Let's see. Waveforms in ECG. So always remember, positive electrode is always a reference electrode. Depolarization wave moves toward the positive electrode, gives the positive deflection. Depolarization wave move away from the positive electrode, gives the negative deflection. And you know guys, so in the ECG, we have waves, we have segments, and we have intervals. So this is the waves, our segments and interval. They are shows to us difficult process of distribution of the excitation of the heart. P wave, waveform. So we have actually wave, we have complex, we have segments, and we have series. Baseline, they are actually flat, straight, and isoelectric line. You should learn the definition of this terminology. Waveform, deviation of movement away from baseline, maybe upward or downward. Segment, this is the line between two waves. Interval, a wave from plus a segment. This shows time duration. Complex, combination of several waveform without segment. So if of course if you have a copybooks and if you have a pen or pencil, you can write it in your copybooks. It will be like something like writing it, because I know you can do screenshot or load this lecture, but when you are writing, there's something what I say to you, so it means it's important and you should remember like 70-80% by writing. By listening, by reading, you will remember like 50%. So that's why I advise to you write in your copybooks. Okay, let's see back. So we have P wave. Yes, they're shown to us at depolarization. QRS complex. So they are, yes, show the ventricular depolarization. T wave, ventricular depolarization. So we have QRS complex waves, but we also have a segment I will show you later, an interval I will show to you later. Here is in this slide you can see here our PQ interval, but sometimes they say PQR interval. We have, we have ST segment, ST segment. Look at this. And then also we have QT interval from QT interval. So again, we have QRS complex, PT waves, then PQ interval, then ST segment, QT interval. So see guys, actually we'll try and understand what does it mean. So what I asked my questions to you, it was like the first questions how, not first, the questions how excitations going on in atrial. I asked about this one. So see yellow colors, how the excitation is going, starting, and pay attention what is happening in the ECG. So the formation of P wave, but P wave consists of the two representation of two atrium. Don't forget about it. P1 and P2. P1 and P2. P1 it is the right atrium, P2 left atrium. In this slide, then also they show how what is happening at the ventricles after reaching the node, and pay attention also the ECG, how they are reflect the every waves and complex QRS, how they are reflected it. Here is so SA node starting. Okay, we know this one, we also know this one, we know this one, and in this one. So let's remember a little bit the form and the size of the complex. Why it will be goes, so why the shape will be so long or short, and it depends, you know, the size, the amplitude, the voltage, everything depends on the momentum of vectors, the purple color. It depends of momentum of vectors, whereas vectors goes to the positive or negative electrodes or to the positive electrodes. Here is positive or negative electrodes, or to the, pay attention, way where goes our waves. Actually, this is the pictures. They show us like we have asthenic people, we have hypersthenic people, and the heart also can depend on the type, personality, genotype of the persons. Like asthenic people's heart will be more vertical. Hypersthenic heart, it can be more horizontal. So of course it will depend. So your ECG will show a little bit differences. The form of the complex and the size of the waves depends on the magnitude and directions of the projections of the moments of vectors. of the EMF of the heart. So there is the where it goes. So number A, not number A, letter of A, what shows to us when the momentum vectors goes perpendicularly to the ECG, and they are what to do? Give a deflection from the isoelectrical lines. A. So that's why you will see the picture in your ECG like this one. They are goes perpendicular. Look at this. 0.02 second. What is happening? It goes perpendicularly, and in your ECG you will see these pictures. So isoelectrical lines. Then what is happening? But if during the excitations the vector change the directions towards to the electrodes, so it can be double phase. It can be double phase. So you also can see this one, double phase. For example, this one. Look at this. Your vectors, moment vectors, decided to go to different directions, change the directions. So the average or the result vectors, you should see the complex, right? This one. Look at this RS, double phase, negative and positive. But mostly you will meet when the momentum vectors goes the perpendicular towards to the electrodes, and you will see PQRS. But you should to understand how it will be located in every leads. For example, in the standard leads, 1, 2, 3, or in the argumented leads, AVL, AVF, AVR, or how it will be looked in the chest leads, from V1 to V6, 7. Okay, that's why let's talk step by step of every wave. So already you know what does mean P wave, and I advise to you to write this slide also in your copybooks, because it's also important till your studying till the 10 semesters. All the teacher of therapy or cardiology teachers or in the hospital, they will ask to you the normal P, same about normal P. So you should to say it's like about 0.1 second, something like a 2.5 small square, and height is 2.5 millivolt. It's a 2.5 small square. And the presence of P waves in ECG shows the signs rhythm. So if you don't find P in your ECG, it will be not science rhythm. If you find the P in your ECG, it will be science rhythm, and be happy. That is its science rhythm. You can save the patient's life. So please write in your copybooks. Okay, let's see next. Here is actually our P wave. You can see this is picture and you're like, oh my God, what is this picture? Again, Ma'am Guljan starts something strange things. um, no, it is easy to understand, nothing to do. So you can see, you can see how our P, the purple color P, here is again P, located in our leads. Number standard leads 3, 2, 1. Here is will be 1. AVL, AVR. So you can see it depends on the vector's moment. Depends on the vector's moment. So mostly at the leads number 1 and number 2 second and number 1, you will see more better P. You will see more better P at the P1 and P2, P at the first lead and at the second lead, because the momentous vectors goes towards to the positive electrodes. Positive electrodes. But you also can find at the P3, but sometimes at the P3 it can change. It can be like, you know, double phase. And if the people, for example, if the people asthenic type of constitution, so their heart will be more vertical, and that's why the P will be parallel to the AVF. Here is this one. This is the asthenic constitution's heart of the person. And look at this. In the asthenic people, their P will be more vertical towards to them, perpendicular towards to the electrode. That's why P is increasing at the leads number 3 and the AVF, but decreasing at the leads number standard leads 1 and the AVL. Even P at the AVL can be negative. So you can see, look at this. So P, if this is the asthenic people, their heart is located, this is the like mostly commonly you will face, this is the vectors. But if the constitution or genotype of the person is the asthenic, so their vectors is goes perpendicular towards the electrodes. So you will find more better in which AVF, look at this, how looks the AVF, leads number 3 and leads number 2, but what is happening at the AVL, at the leads number 1, it can be isoelectric because there's the equal to the 0, and at the AVL it can be decreasing or even the negative, because the vectors is located here. But at the AVR it will be always negative. Look at this. So here is the P vector is located almost parallel to the second of the standard lead and is projected onto the positive parts of the lead axis of second AVF 1 and 3. This is about this one, about A picture. AVR always negative. At the AVR, you will always find the negative P. At the AVL, it will be two-phase or low amplitude. Look at this, two-phase or low amplitude. But what is happening if the person is asthenic, this picture? So the P vector is located almost parallel of AVF, look at this. That's why P is high and in the lead number 3 and AVF. But P wave will be what? Low in the 1 and the AVL, and even, you know, guys, can be negative, even can be negative. Okay, so what is happening with the hypersthenic people? What is happening if the heart of the hypersthenic type of constitutions or genotype is hypersthenic? So their heart lies more horizontal, okay? Asthenic people, their heart more vertical, but the hypersthenic people, is more horizontal of the heart at the chest. So the vector P parallel of exists the first standard leads. You can see this one. Look at this one. This is the vectors. So horizontal position of the heart vector P is parallel to axis of the lead first. This one is the lead first, not AVL. Lead AVL of the first lead amplitude P increases in 1 and the AVL. In 1 and the AVL. Therefore get to mention Y1. This is the AVL belongs to this picture. Here, this is the lead number 1. So P can be two-phase or negative at the left atrial hypertension. So in this lead, P will be what? Decreasing, AVF decreasing, three leads will be negative. And actually, when there is the P double two-phase or negative, it shows what? If our 1 and AVL, this is the P will be double or negative, it shows there is the left atrial hypertrophy. I have a question. What does mean left? What does mean atrial hypertrophy? Who can explain to me? Without Google, please. You should study hypertrophy in the PET phys. So what does it mean?
When increase in the size of the heart is called hypertrophy.
Can you please more in detail, size of the heart, size of what part of the heart?
Ma'am, most of the left ventricle, due to the forceful contractions, there will be enlargement of the left ventricle.
I ask again, can you tell please size of heart? I am agree with you, it increases in size of heart, but I need which part of the heart increases the size?
Ma'am, myocardium.
Myocardium. Thanks, God. Yes, myocardium. Don't forget. So, if you notice that the P in the leads 1 and the AVL negative or two-phase, so you can say there is something happening with the atrium, and mostly the reason is the hypertrophy, increasing the size of the myocardium of atrium. Okay, guys. Okay, so what is happening in our chest leads? Chest leads. So you can see what is happening in our chest leads. How the vector is lies. Look at this. They are, everybody goes to the positive electrodes, mostly at the chest leads, you will identify good leads number V4, also V5, V3, but at the V2 and V1, there will be double-phased or two-phased, because the vectors is go to the parallel of the electrodes. So you will see this one of pictures. Here is, you are sitting and thinking what she is saying to me, and leads and parallel and blah blah blah. I'm saying here is your ECG. So the patient gives to you, see a doctor and give me interpretations or explain to me. So what you will say? Now we know about P. We know all, we know all about P. Here's P, 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 here's again P. This is also P. Here's standard leads number 1, 2, and 3. Again P. Here's our P. And look at this at the leads P, how it looks like P. Then in augmented leads, pay attention of the P. They're negative. Look at this, negative. Do you remember? I say to you, at the IVR, the P always negative because it's located at the negative poles of the electrodes. That's why it always will be negative. Look at this. Then IVL, you can find it, but it will be decreasing the size. And AVF, here is P. So V1 at the chest, I said they are always almost positive. They are almost always positive. But at the chest wave, you can see more better our V at the V5, V4, V3. Here is V5, you can see more better. V4, V3. But in other leads, there will be, they are, but the size and amplitude will be very small. So, and I said, what I said, if there is the hypersthenic people, so the P at the lead of 1 and AVL, 1 here is an AVL, here is 1 here and AVL. What can happen? They will be two-phase or negative. So your patient is the hypersthenic type of patients, and if you see double phase, double P in 1 and double P and negative in 1, you can say something happening where here is something happening with the atrium, hypertrophy of atrium. Okay. And now I have a question. Can Can you please, guys, give me interpretations of the P at all, like something summary or result of P? And GM1, Ali, you hear me?
Yes, ma'am. Yes, ma'am. You can, ma'am.
Can you loudly, please?
Yes, ma'am. Can you repeat the question?
Give me a characteristic of P at all. Everything what you know about P.
Ma'am, the P wave, first of all, we know what puts the neck.
Who wants Abbas GM18?
Ma'am, I will note the ma'am, it is located parallel to the standard lead projected to the positive part.
No. Start from P is wave show to us depolarization.
Yes.
Start from this one.
Ma'am, the P wave ECG shows the electrical depolarization, which results in atrial contraction or the atrial systole. Normally the right atrium depolarizes earlier than the left. So that occurs in the which wave originates in the SA node, and the high atrium travels through and to the left atrium.
Okay, I understand. P wave shows to us depolarization of the atriums. Next one, next point. What is also important of P? How much time it needs to get the excitation of two atriums? If you don't know Ali GM1, so who knows?
Ma'am, can I tell?
Yes, please.
2.5?
Yes. Ma'am, that the duration of P wave will be 0.1 second, which will be equal to 2.5 small square.
Okay.
And if we talk about its height will be 2.5 MV, which will be equal to 2.5 small square.
Okay, next one.
The presence of P waves in ECG shows strip the sinus rhythm.
Next one. How it will be P in the standard leads, how it will be P in the augmented leads, and in the chest leads.
Ma'am, two different points on the body, it's called bipolar leads. And
okay, guys, I hope in one of the happy day you start to study. I really hope, because it's something like I'm like blah 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 talking by myself, explain something, but you don't want to even understand. It's not good. It's like, you know, it's not interesting. Maybe quite the lectures with the fourth semester. I don't know what to do. Maybe say to administrations like, I don't want to give the lectures to the first semester. What do you think?
Standard leads. In standard leads, there is positive deflection, and in augmented leads, there is negative deflection. In augmented leads, negative deflection is that's why it's because the vector is opposite upward side. Current is traveling, so that there is negative pole on right side upward. That's why in augmented leads there is negative deflection.
Okay, thank you. Okay. Okay, let's see next one, what we have next one. So here is number 1. Normally in the leads of 1 to AVF, V2, V3, the P wave is always positive. 3 AVL, V1, P wave can be positive, double phase and sometimes negative, and AVR wave, P always negative. So I hope if you have a pen and copybooks, you will write this one in your copybooks. Okay, let's see next. In this picture you can see abnormalities. Здравствуйте. Как вы? У вас вопросы? Да. Не слышно? Спрашивайте. Give me 5 minutes, guys. 5 minutes break.
Okay, ma'am.
Okay.
Okay, I'm sorry. So, in which situations we can see abnormalities? It's a P pulmonale. This is a tall and peaked P wave in the lead 1 and 2, 3 in right atrial hypertrophy, pulmonary hypertension. P mitral, it is the biphasic or broad P wave seen in left atrial hypertrophy, mitral stenosis. Mitral stenosis, it's a disease of the cuspid of valves of the heart, best seen in the lead 2. So about the abnormalities of the P, you will study more better and more in detail with the other teachers, not with me, in the respiratory system. You will study about the P waves, why it's P pulmonale, why we call P pulmonale, or why we call P mitral. So you can ask your respiratory teachers, means clinical respiratory teachers. She will explain to you. I don't want to explain because it takes very long time. Okay. Here is there show to us how actually P looks negative at the AVR, how looks at the AVL and at the AVF. So there is the differences almost in the size. Okay, let's talk about the PR interval. PR interval, we have PR interval, but we have also P segment, okay? You should to very clearly understand segment is segment, interval is interval. It cannot be the same thing. Here is, look at this. P interval start from here, from the beginning of the P and end here till the R. even till the QR. This is the interval. But P segments start from here until the QR. So don't confuse what does mean PQR segment and PQR interval. This is the differences. Okay, let's see what is this PR interval. This is the from beginning of the P wave to the beginning of Q wave. Its normal duration is from 0.12 to 0.2 seconds. It represents the conduction time of impulse from the SA node to the ventricle and AV daily. So write in your copybooks this one, because it's also important. Okay, so here is interval reflect the duration of the AV node. Interval, PQR interval, they actually reflect the duration of the AV node. And always forget, or not forget, remember if you will study. Duration 0.12 till the 0.2 second. And you know, if the person's heartbeat rate will be increasing, so interval of PQ will be decreasing. If the heartbeat rate of the persons will be increasing, so interval of the PQR will be decreasing. This is the like prolonged PR interval. Prolonged PR interval shows delayed conduction from SA to AV node in first degree heart, second degree, and complete heart block. Digital therapy and hyperkalemia. It's also like abnormalities of the PR, but I say to you, abnormalities of PR you will study with your respiratory clinical teacher. Let's talk about the QRS. Let's talk about the QRS. So QRS, actually, it is the complex. It is the complex. Represent the ventricular depolarizations. It is the complex that is represent the ventricular depolarizations. Everybody knows it, and thanks God, everybody knows it. Its normal duration is about 0.08 seconds, less than 2 small square, and height is about 5 to 20 small squares. It is a wide complex because it masks the atrial repolarizations. Q wave is first wave of this complex but often absent. You will say me, what does it mean? It is a wide complex because it masks the atrial repolarization. How you understand these sentences, guys? How you understand these sentences, guys?
And the ventricular depolarization is that's much strong. At the same time, when the atrial depolarization occur, it is masked, like
okay.
It is not shown in the graph.
Your name? Can you tell me your name?
Abbas.
Okay, yes, you are right. Due to because repolarizations of the P lies at the same time of the depolarizations of the QRS. That's why it is a wide. Please write in your copybooks. Okay, let's see next one. So P wave present the intraventricular septal depolarizations. It is the first wave in ECG with negative deflection. Q wave greater than 1/3 the height of the R wave, greater than 0.04 seconds are abnormal and may represent the old infarction. Okay. Here is the most common options of QRAs. You can see how actually QRS can be seen. So it can be QRS. Pay attention how QRS can look like this one, or it can be QR. The S is disappeared. It can be RS. It can be only R. It can be RS or QR or little rs, little r big S, or little r big R and S looks like letter M, or RSR or QS or QS. So it depends on of the sizes. QRS depends on of the sizes. If it's more, the waves of QRS, it is more than 5 millimeters. So we will write big Q, big Q, big R, big S. If this is waves is in small 5 millimeters, then the 5 millimeters. So we will write small Q, small r, and small s. So but you will ask me, what does it mean this? What is this one? Who can answer me? What this one? Guys, who knows? What does it mean? What does it mean? I don't understand. P prime, what do you mean P prime? Who knows? You can tell me if you know. Actually, you know, guys, we put this mark when there is the 2 R's. Look at this, 2 R's, little r and big R. So that's why we show this is the mark, little r, big R. We show this mark. For example, if we will have one more R little, 3 R's, so we will put here one mark also. Okay, is it understandable?
Ma'am, is it like the R wave is, this one is R prime wave? So when there is a right bundle branch block, so there are 2 R's present. One is R and then other is R prime with a sign on it.
Yes, so it means you can see when there is the present little r's. Okay.
Yeah.
Okay, here is not working my words. Here is our QRS. Okay, let's see what is happening. What is happening with the Q? We will talk about the Q. So typically, the Q wave can be recorded in all standard leads and unipolar leads from the extremities and chest leads V4, V6. Okay, so here is again, it depends where is our vectors goes, and the little q, they are actually v4, v4, and the v6, 5 and v6. You can see q more better. But remember, the amplitude of the Q wave in all leads except for AVR doesn't exceed 1 to 4th of the height of the R wave, as duration is 0.03 second. Remember this one, and please write, this is the sentences. This is the sentences. Actually here, Q actually represent to us excitations of the interventricular septum. Interventricular septum. And here is 002 second. 002 second. Vectors goes here. That's why it is negative. That's why it is negative here. Here is negative because the vectors, they're directed negative electrodes. That's why it's negative going downwards. And it shows to us the beginning of excitations of the ventricles, interventricular septum. So please guys write these sentences in your copybooks. Okay, next one. So actually in this picture you have already known this picture, how excitations step by step goes. First of all, in the 0.0 second excitation goes interventricular septum, and pay attention the purple colors vectors directions. Then at the 4 points for 4 and 5 seconds, it goes to the walls, to other walls, lateral, anterior, posterior walls of the ventricles. And pay attention of the two ventricles. Pay attention again to the vectors of this excitation. Then at the 0.06 to 0.08, it is at the finally excitation goes towards the what? Basal part of the heart, basal walls of the heart, and pay attention where is our vectors. Upward, then they go to the upward. So that's why you can see our R. Let's talk about the R. Typically, the R wave can be recorded in all standard augmented limb leads. In the lead AVR, the R wave is weak or absent at all. You can see AVR, it will be even disappeared. Look at this, even disappeared. Why? Because the vectors goes at the positive electrode. So our R can disappear, and you can see it in AVR leads. In the chest leads, the amplitude of the R wave gradually increases from V1 to V4, then decreases slightly in V5, V6. So you can see again our chest leads, and from V1, V2, V3, V4, it will be normal. It will be step by step increasing, and after the V4, V5, V6, it will be decreasing. So at the V4, at the ECG, at the V4, you will see the most high amplitude of the R due to vectors. But at the V5, V6, it should to be decreasing. I say to you why. I mean why it's important, because in the hypertrophy of the myocardium of the ventricles increase in size, so V5, V6 R will be increasing in hypertrophy. That's why normally in ECG, V5, V6 should to be decreases after V4. Then the RV1, V2 wave reflects the propagation of excitation along the interventricular septum, and then RV4, 5, 6 wave along the muscles of the left and right ventricles. The interval of the internal deviation of lead V1 does not exceed 0.03 seconds, and in lead V6, 0.05 seconds. So for you is important this one. Write these sentences. In the chest leads, the amplitude So yes, you can see how looks like our V, our R. So at the 3, it will be not so long. At the AVF, it will be long. And the leads 2, it is also will be long, because 0.04 seconds vectors is shows towards the positive electrodes at the leads 2. At the leads 1, it will look like that. AVL, it will looks like that. So see guys, there will be changing, and this is the changing. You must know the normal, because in abnormalities you will confuse. Here is actually show to us the interval deviation in lead V1 does not exceed 0.0 second, and lead V6 does not exceed 0.05 second. So it means for this one, you should to use, I will show to you, ruler for ECG. So when we are will face to face, I don't know, with me or with other ECG teachers, face to face or in clinical, not online, offline, you should also to have the ruler special for ECG. This is the ruler actually shows to us the size 0.01 size, 0.2 size, or 25 millivolts, the height of the size, everything. In the shop there are different types of this ruler, really. So you will understand this is the interval of internal deviations by using the rulers, okay, by using the rulers. Here is again our ECG, and in this ECG you can notice how our QRS is located. So I say to you, it should to be, there, here is this one. This one is our R. Here is R. Don't confuse with the T. This is the T wave. Here is R. Here is R. R. And here is long R at the V4. Then it should to be decreasing V5 and V6. It is the normal. It is should to be. Then we said we can very long C at the 2 leads, at the 3 leads, at the second leads. This is the like a, ECG can gives to you repeating second leads, repeating second leads. Pay attention what is happening at the AVR, QS. There is the what? There is the no R, maybe little r. Maybe you can identify, but it will be little r, but it will be S, QS, actually mostly. It's the S. Here is AVL, again, look at, and what is happening at the AVF? It is getting what? Positive. Okay, let's see. Read this line. Abbas GM18. Everybody like sleeping or what? I said read this slide.
No, ma'am. When the height of our S wave is not more than 5 millimeters, it is seen in hypothyroidism, pericardial effusion, thick chest wall, problem in ECG machine.
Okay, next slide, read please.
The S wave is the most downward deflection of the QRS complex that occur after the R wave. In the normal ECG, there is a large S wave in V1 that progressively becomes smaller to the point that almost no S wave is present in V6. A large slurred S wave is seen in leads 1 and V6 in the setting of a right bundle branch block.
Okay. Here is our S wave amplitude in different leads varies widely, no more than 20 millimeters. You can also read in your copy books the amplitude of S wave different leads varies widely, but no more than 20 millimeters. In the chest leads, the S wave gradually decreases from V1, V2 to V4, and in leads V5, V6 has a small amplitude or is completely absent. Please also write in your copybooks. Here is, you can find your S in this slide as look at this. This one is S. This one is S. This one is S. Here is S. Read this slide.
High voltage QRS complex. This is present in ventricular hypertrophies. The maximum voltage of QRS complex may be 35 MV 35 small square. V1 and V2 show high voltage QRS complex in right ventricular hypertrophy S wave. V5 and V6 show much QRS complex in left ventricular hypertrophy R wave.
Okay, thank you, Adil, GM5. Here is, look at this. Again, for measure, you should to have a ruler. This is the segment RST. The segment is located on the isoline. Normally, it can be till 0.5 millimeters, but if it's more 2 millimeters, it means there is some ischemia of the heart. T-wave, read the slide.
T-wave, it represents a ventricular repolarization. It is repolarizing wave but shows the upward deflection because the part depolarized in the last is the first to be repolarized. That is the base of heart depolarized in the last but in first to be repolarized.
Thank you. You know, guys, what? How many students we have at the fourth semester? Who can tell? Again, I ask the questions. How many students at the fourth semester do?
I don't know exactly, but at the first time we were about 256, and many students left the university.
100 students leave the university. Wait a minute.
I don't know exactly, but
No.
Ma'am, approximately 170 to 80 students.
Yes, ma'am, 170 to 80.
Yes, ma'am. 100 to 70 to 80, maybe.
How many students we have?
Ma'am, approximately 170 to 80 on
Ma'am,
regular basis taking classes.
don't know the exact figure, but 170 or maybe 180 students.
Okay, so I don't know, group leaders, how you find your members of the groups. This is your problems, leaders of the groups. So your job for the next lecture, find all the members of your groups and everybody should appear in my lecture. If there will be not 170 or 80, I will done my lecture with the fourth semester. Understandable?
Okay, ma'am.
Yes,
Okay,
ma'am.
ma'am.
Okay, thank you everybody. Bye.
That's Vidani, ma'am. Have a nice day, ma'am.
Okay, ma'am.
Yeah.
Bye bye.